President Trump and Congress's big, beautiful bill is now law. How will the drastic cuts to healthcare affect you and your family? Welcome to Care Talk, where we talk about how healthcare works or doesn't work in America and answer your health insurance and healthcare questions. I'm Laura Packard, cancer survivor and healthcare advocate, here to help you. Please text or call in your questions at 202-838-6837, and we'll answer them in future episodes. Be sure to subscribe to my channel or podcast wherever you get your podcasts to get next week's show. In today's episode, healthcare expert Natasha Murphy from Center for American Progress returns to tell us more about what was in the final bill and how it will change our healthcare. So welcome, Natasha Murphy, Director of Health Policy at Center for American Progress.
Hey, Laura, thank you so much for having me back. Unfortunately, it's not under the best circumstances. Over the past 6 months or so, I know so many in the policy and advocacy community were incredibly concerned about all the provisions really and what became the One Big Beautiful Bill Act. And happy to talk more, like you said, about the specific healthcare provisions and what it's going to mean for millions of Americans.
Thank you, Natasha. So let's start. There were various Medicaid cuts in the House bill and the Senate version that have been talked about for several months. And so there are Medicaid cuts, there are Affordable Care Act cuts, there are even repercussions for Medicare with the final bill. So tell us what made the cut.
Yes. So I know there were so many different variations across the different versions, but what was signed into law on Friday as it pertains to Medicaid? So I think at the forefront of everyone's mind were the burdensome paperwork requirements. And so what was finally passed and signed into law effective 12/31/2026 for most states and no later than December 31st, 2028. Individuals who have Medicaid coverage through the ACA's expansion, if you are between 19 and 64 years old, in order to maintain your coverage, you are going to have to prove and report that you are either working 80 hours per month or participating in some other type of qualified or approved activity like volunteering. And so that was a provision that was relatively consistent across the House and then the Senate version. But I would flag one additional change in the final version. And that is the fact that parents are not broadly exempt from these burdensome paperwork requirements. If you are the parent of a child over the age of 14 with Medicaid coverage through the ACA's expansion, you now will have to comply with these work requirements in order to maintain your coverage. So that was, one big change. In addition to that, something that I think didn't get quite as much attention, but I do want to make it very, very clear for the listening audience, is the fact that beginning in October of 2027, states are actually going to be required to charge Medicaid enrollees with household incomes up to 138% of the federal poverty level, which is a little bit over $15,600 a year. New cost sharing. And so states will be able to charge up to $35 per health service in co-payments or cost sharing amounts. And we're really concerned that this is going to cause people who already have limited resources to not see their doctor because they're having to make those hard choices between other needs. And then finally, I would flag that the mechanism that states use oftentimes to help raise money to fund their portion of Medicaid, so those are the provider taxes. In the Senate final version of the bill, states are now limited in their ability to raise provider taxes. And so it lowers them from 6% to 3.5% between now and 2032. So those are some of the big ticket Medicaid changes that impact both individuals as well as states.
Thanks. And so you said that these paperwork requirements go into effect December 31st, 2026. So that's the end of next year. But we're already seeing hospitals, like a hospital in Nebraska that closed because of these impending Medicaid cuts. So we're going to see effects sooner than 2027.
Yeah, Laura, I think there's before I think there was a lot of uncertainty, but now that we do know what provisions were actually in the bill, the industry and the broader healthcare ecosystem is reacting. Like you mentioned, a hospital in Nebraska announced, I think a few short hours after the bill was signed into law, that they were actually going to be closing because they were already, kind of financially strapped, and recognizing the significant coverage losses that are on the horizon, they knew that they would not be able to continue to operate. And so while some of these effective dates feel like they're months off or some years away, the impact is certainly being felt now kind of a bit more immediately.
And I also want to cover the Affordable Care Act. What is not in the bill is there is no extension of the support that was in the American Rescue Plan and the Inflation Reduction Act to make health insurance more affordable for middle class families. So people are going to see that right away in September when they see their insurance premiums for next year. We're going to see people on the Affordable Care Act, like myself, we're going to see our rates increase in the next couple months.
Yes, yeah, like you mentioned, the lack of any type of legislation or inclusion of the enhanced premium tax credits that have vastly improved affordability of ACA coverage for the middle class and was set to expire at the end of the year. It was not included in this one big, beautiful bill. And so as a result, they will expire. And we've already started to see the way that insurers have reacted to that. Over the past few months, insurers have had to file their 2026 proposed rates, and nearly all of them recognize that there were going to have to be steep premium increases due to the loss of these enhanced tax credits. And so, like you said, around that August, September timeframe, when folks start to get their renewal information in the mail, we anticipate that more than 20 million Americans are going to see premium increases, some as high as 75%.
That's frightening, and that is imminent. And I think what hasn't been talked about too much is that there's a technical issue with the way that these cuts in this bill were made, such that there may be cuts to Medicare because of sequestration that are coming as well. Do you want to speak to that?
Sure. Yeah, I agree that there's been a lot of focus naturally on Medicaid and the historic cuts there. And then, of course, the lack of action that is going to skyrocket premiums in the ACA marketplaces. But the lesser discussed topic is Medicare. And so the One Big Beautiful Bill Act actually ends up blocking the implementation of existing regulation that makes it actually easier for low income Medicare beneficiaries to enroll in the Medicare savings program, which really helps to lower their premiums and out of pocket costs. And so, despite the president's claim that, Medicare was not going to be touched and older adults were kind of exempt from any of the changes from reconciliation, a lot of the sloppy drafting and just the rushed process has resulted in the fact that we are going to see an impact on older adults.
These massive cuts, over $1 trillion to our healthcare system over the next few years, is there any way that states can make this up? If you're in a more wealthy state like New York or California, are you going to be okay? Or is every state going to face devastating cuts?
Yes, given the sheer loss of, adequate federal financing or, facing millions in coverage losses, I honestly can't think of a single state that has the wherewithal and fortitude, even the Californias and New Yorks of the world, to be able to kind of absorb these types of cuts. And I will say, there are some states in response to the signing of the legislation on Friday who are considering, embarking on special sessions to try and figure out how they can shift resources around or identify more creative ways to try and support and protect their residents from, these historic cuts and the anticipated changes. But ultimately, it is going to be almost nearly impossible for states to, kind of simply absorb and, be able to fill the gap that's left. But I will say, given that reality, I would actually anticipate to see, action from state attorneys general as, they kind of identify the full breadth of these cuts. And so I do anticipate starting to see, lawsuits pop up as states indicate, particularly on the provider tax front, that they are going to be irreparably harmed by some of these changes.
Thank you. And actually, one of our viewer questions from Tommy wanted to know if this bill does become law, can it be challenged at the Supreme Court? And what you're saying is that, yes, parts of the bill attorneys general can sue, maybe other people, insurance companies, hospitals, maybe other doctors, like the American Medical Association, like other groups at stake could file lawsuits, and the parts of this could go through the courts?
Yeah, given the sheer impact and magnitude of particularly the healthcare provisions in the law, the fact that it touches nearly every element of the healthcare ecosystem, there are so many individuals and parties who I do expect to take some type of legal action. When I think about, the last piece of legislation to have an impact this broad, it's the ACA, which is one of the most contested laws in American history. So it would not surprise me over the coming months and years for us to see litigation pop up in regards to the one big beautiful bill.
Right. And in fact, the various big pharmaceutical companies have been and are still suing parts of the Inflation Reduction Act because they don't want to have to drop their prices for prescription drugs. So there will probably be many lawsuits about this bill, and we'll stay tuned on that. But whether parts of this bill are paused or are struck down by the courts, we just don't know, won't know yet. So what, given all of the terrible things that are in this bill, but also given that it was signed into law, is there anything that the average person can do about it right now? If you are on Medicaid, if you get your insurance through the Affordable Care Act, and you're going to be facing higher costs next year or the year after or so on, what can you do about it right now?
Yes, great question, Laura. And yes, in the face of such awful news and, honestly bad policy, I do want people to know that they are still empowered and there are still steps that they can take. So first, I would start with individuals who have ACA coverage. Like I mentioned, towards the end of the summer, you'll be getting a notice or a letter from your insurance company with your proposed 2026 rates. And there is a strong possibility and a strong likelihood that you are going to see a significant increase. And so I really encourage everyone with marketplace coverage that this is the year to plan shop. Come November 1st, please, log on to healthcare.gov or your respective state-based marketplace and explore the different plan options that are available for you. I know a lot of people, they like to stick with the coverage that they have. And so in previous years, maybe they just re-enrolled into the same plan. But given the premium increases that are expected, it's going to be really, really important for folks to do that active plan shopping. For individuals with Medicaid coverage, I really encourage everyone to make sure that they are actually keeping their contact information as up to date as possible with their state Medicaid agency. And that's just in preparation for these burdensome paperwork requirements. You want to make sure that their contact information is up to date, so that you can get, all of the notices, all of the information to allow you to be in compliance, once these policies are implemented. Again, there's a little bit more time on that front, but it's really, really important for folks to kind of stay aware and stay active in the current place that we are. And then finally, I would say that right now, your state elected officials and state administration officials are paying attention to this particular policy topic, especially as it relates to Medicaid. And so I do think that there's still an opportunity to advocate at the state level. Given the breadth of these cuts, unfortunately, previous experience tells us that when states are in, a harsh financial situation, they may consider cutting some of the optional Medicaid benefits like home and community-based services. And so I think there would be a lot of value for individuals to contact their Medicaid agencies, contact their insurance administrators, and let them know, share your personal stories about, how important something like home and community-based services have been to you or your family. Because it's really those personal perspectives that can help remind, at this point, our administrative and regulatory officials the importance of preserving those benefits and coverage.
Thank you, Natasha. As you pointed out, this bill has been passed by Congress and signed into law, but how it will affect you will depend a lot on how your state implements these cuts. And so your governor and your state legislators need to start hearing from you now about what's important and what they need to make sure to protect. And make sure that you know how your senators and your congressperson voted, and they need to hear from you too, because however they voted on this bill, this is not the end of it. There are things they could do to make things better in the future, but they won't take action unless they hear there's a need to take action. So even though your representative or your senators may have voted for this terrible bill, they need to still hear from you, and they need to hear from you even more, that you're not just going to forget that you lost your health care. You're not going away, and this is their problem now too. So thank you very much for joining us, Natasha. Thank you for all the work that Center for American Progress does for keeping us informed on this issue, and keep informing us.
Absolutely. Always a pleasure. Thanks for having me again, Laura.
Thank you. And now we will answer some viewer questions with Louise Norris of healthinsurance.org and Diane Archer of Just Care and Social Security Works. So let's start with Diane and talk about an email that people may have gotten, I received, about Social Security from the Social Security Administration about changes to Social Security as a result of this bill. So tell us what's in the email and what are the facts.
I'd be happy to, Laura. So the email is very misleading. You're likely to be confused about what's happening to your Social Security benefits if you actually read the email. The truth is that the Trump tax bill eats into Social Security's revenues and weakens the long-term health of the program. And for most Americans, it keeps Social Security benefits just as they are. So most people won't see an end or a reduction of taxes on their Social Security income. For starters, the majority of people who get Social Security income, about 2 out of 3 people, already don't pay taxes on that income because their income is too low. What is true is that some middle and upper middle class households could benefit from what's called, quote, an enhanced deduction provision in the bill. And this deduction could lower overall taxes depending upon people's income. So adults over 65 with incomes under $75,000, and these are individuals, or $150,000 if it's a couple, should see an extra $6,000 tax deduction as a result of this bill. And that's $12,000 if you're a couple. And if your incomes are higher, you could get a lower deduction. But you get no deduction if your income is above $175,000 as an individual or $250,000 as a couple. And adults between the ages of 62 and 64 get no deduction. So in sum, the Trump bill reduces taxes for a small subset of people receiving Social Security benefits, but only a small subset. And unlike the tax reductions for the ultra wealthy in the bill, which are extensive and go for at least 10 years, this tax benefit is only in effect for 4 years, beginning this year in 2025. So that's the truth about this bill and Social Security benefits.
Thank you, Diane. Our next question is from Meg, who wants to know why don't we pattern American medical care, our healthcare system, after the South Korean model or any number of other countries that have reasonable medical coverage for all of their people? So, Louise, why do we have the system that we have, and why don't we have a better system?
So that is a great question. So I'll start by saying anything is possible. It depends on who we elect into Congress and the White House. You can make changes. You can make significant changes to the way the healthcare system works. Just because we haven't yet doesn't mean that we couldn't. But, you know, if we look back on the Affordable Care Act, which is nowhere even close to universal coverage or a single payer system, it was a massive battle to get that signed into law, and ended up being a very partisan topic, even though it didn't at all delve into, you know, creating an actual single payer system. It relies entirely on private health insurance markets, but it was still very partisan, very controversial at the time, and has continued to be controversial and in and out of the courts. It's been at the Supreme Court 3 times. So healthcare reform in the United States is a challenging partisan issue, and oftentimes does get hung up in the court system. What we currently have is just a hodgepodge of a mix of public and private coverage with different price points, different eligibility rules. It varies from state to state. So there's just, it is quite the system that I don't think anybody, if you were starting from scratch, nobody would design such a complicated hodgepodge system, but this is what we have, and it exists. We've been gradually building it this way for decades and decades, and it's a combination of all sorts of different federal and state rules and regulations. So changing that is very challenging. In large part because there are so many competing interests that have a financial interest in either keeping the status quo or changing it a certain way that maybe doesn't appeal to other stakeholders. So even in the public health coverage sectors like Medicare and Medicaid, the majority of enrollees are actually enrolled in managed care plans that are run by private health insurance companies. The majority of Medicaid enrollees and the majority of Medicare enrollees are in either Medicaid managed care plans or Medicare Advantage. So this is, even in our public coverage programs, there's a huge influence from private health insurance companies that obviously have a financial interest in keeping private health insurance companies in the system. And then there are also the entities like medical providers and hospitals that want to keep their reimbursement rates as high as possible. The public systems like Medicare and Medicaid generally pay them less than the private commercial insurers. And so when there's talk of moving to a more public system, the medical providers are concerned about their reimbursements dropping. So that's another competing interest there. And then you even have just stakeholders who are focused on certain issues within, like, what would be covered by a single payer system. If we look back in 2016, Colorado was an example. There was a ballot measure on the Colorado ballot that year to create a single payer system just within the state of Colorado. And one of the groups that was actually opposed to that was a very pro-choice, very progressive group that their big concern was, at the time, Colorado had in the Constitution that public funds couldn't be used for abortion. So the single payer system would have not covered abortion at all, and that would have removed coverage for people who already had private health coverage that did cover abortion. So you can see, when you look at that, you can, depending on what the issue is that we're considering, entities from different ends of the political spectrum and different interest groups can be opposed to a measure that you might be talking about for a single payer or universal coverage program for very different reasons. But it can end up scuttling the whole thing just because people can't agree on what should be covered, how much should the providers get paid, how much should people have to pay in taxes to support this. It's very easy for entities that are opposed to a universal coverage or single payer program to scare people, to make people think, oh, well, this means you're going to lose your health coverage, your taxes are going to go way up. The nuance and details are usually obscured. Like if your taxes go up, are you accounting for the fact that the premiums you pay and the out-of-pocket costs you pay might go down? Those sort of nuances often get lost. So what we tend to see when there's talk about this is a lot of sound bites that are short and usually don't get into the nuance and scare people, because a lot of people are happy with the coverage they have, and they aren't being told the nuance of maybe what might happen with various proposed changes. So it's easy for people to sort of drum up opposition. So that's why we are where we are with the U.S. health coverage system, just continuing to be sort of a hodgepodge of all sorts of different programs and price points and eligibility rules. But anything is possible going forward.
Thanks, Louise. As you pointed out, it is easier to break things than it is to build them. But this bill that just passed is going to do a lot of breaking of our healthcare system. And so we will see in the next few years whether people are ready for something new and different. And now for Diane, there was an announcement last week that traditional Medicare in some states would start using prior authorization next year, where doctors need to get pre-approval for some medical services. So this is not now, this is in the future, and this is not all states, this is some states. But Diane, you want to talk about what this is, what's going on?
Yes, I'd love to. So as people, or most people know, in Medicare Advantage, the insurers tend to use prior authorization for any costly procedure, and in ways that can often be harmful to enrollees and even deadly. The Office of the Inspector General at the Department of Health and Human Services has found twice now that some insurers sometimes engage in widespread and persistent inappropriate delays and denials of care and coverage as a result of their use of prior authorization. And it's particularly true for high-cost care. The insurers have a conflict of interest. The more money that they don't have to spend on care, the more money they generate for their shareholders. So as a result, people enrolled in Medicare Advantage often struggle to get chemotherapy, rehabilitation therapy, and skilled nursing care, among other costly services. And moreover, because each insurer uses prior authorization differently and in secret ways, people have no clue when they enroll in a Medicare Advantage plan whether they're going to get the Medicare benefits to which they're entitled, or whether their insurer is going to engage in inappropriate denials. So prior authorization has just been a terrible albatross in Medicare Advantage for too many people who need costly care. Fortunately, most people don't need it, but unfortunately, the people who need it often struggle to get it in their Medicare Advantage plans. So in traditional Medicare, in stark contrast, people rarely need prior authorization to get their care covered. There's an exception for durable medical equipment, but it's a rare instance in which people need prior authorization to get their care. The government doesn't second guess their doctors. If their doctor says a procedure is medically necessary, they tend to get that procedure and it's covered. But of course, the downside is that there are some doctors who try to cheat the system and fraudulently bill the government for services that people don't need or that people don't receive. So the government is testing and launching this pilot, as you described, Laura, in 5 states to test the use of prior authorization on, I believe they're starting with 17 different procedures outside the hospital, so not necessarily the most costly procedures, but procedures that are often fraudulently billed. And we don't know yet how it's going to work with the government in control. It should be more transparent. We should be able to learn whether it can work, but we don't know. And it is scary that this is happening because until we have the details, the devil is always in the details, we can be concerned that prior authorization will be overused, that the companies that implement the prior authorization have an incentive to inappropriately deny care. The good news is that overall, if you're in traditional Medicare and live in 45 states outside of the 5 states selected, you still will not have prior authorization if you need care. Your doctor will determine what care you need, and you will get it if it's a Medicare covered benefit. And in those other 5 states where they will be testing prior authorization, it will only be, at least initially, for 17 procedures and procedures that are outside a hospital setting. So hopefully not the most urgent procedures. And the way the pilot is written, it says that if somebody's life or health is in danger, then it shouldn't be used. So again, fingers crossed that the pilot will be done in a way that is judicious and protects people from inappropriate delays and denials of care.
Thank you, Diane. And we've seen with abortion bans that people's definition of somebody's life or health in danger is a tricky thing. So we will pay attention to how this rolls out and if patients in those states are adversely affected. So thank you for joining us today to learn more about H.R. 1, the federal budget bill that was just passed under reconciliation and the proposed cuts to our healthcare. Please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. Join us next week for more on healthcare in America, and be sure to subscribe to my channel or podcasts wherever you get your podcasts. My name is Laura Packard, and this is Care Talk.